So I invite our next speaker, Dr. Lathika Vasu Kamaladevi. Her topic is the future of myopia control, exciting new technologies on the cards. Over to you, ma'am.
Thank you. So at the onset, let me thank the scientific committee and Dr. Nina for this opportunity to speak on a very contemporary topic. So if I can see that the hall is full, and if all of you are very smug about, being up to date about what is current, then this talk is about what is probably the future. So do we know? So your question, the first question, maybe the present is enough for us. We live in the present. Do we really need to know all about the future too now? But actually, the future is here and it is knocking at your doors. So only the confident will be able to let the future in and, be in step with the future, because the future is colliding into the present. So what we say as futuristic is almost here. And your patient may be much more well informed, and it's up to you to be able to answer their questions. And most of our patients now come with futuristic questions rather than realistic questions. So understand, at least even if you don't practice, we should understand the multifaceted landscape of myopia control to adopt individualized and best practices for your patients. Now, the second question is, do we really need more, or all of this is just hype? Myopia is now a public health priority, and so there is a huge resource burden mismatch. And that is why this emerging tech is important, because it helps overcome resource limitations and it makes everything more accessible to the patient, and it helps in precision medicine, or the so-called targeted therapy, and self-paced interventions. And all of these which we have discussed here probably addresses the compensation of myopia, but these mechanisms address the underlying causes of myopia. So that is why these things are so very important. And coming to an overview of these emerging technologies, we have digital health interventions, light therapy, we have AI-based interventions, gene-based interventions, and pharmacotherapy innovations. So for all this, we should understand that the basic mechanism is the signaling, visual elongation signaling occurring due to the peripheral hyperopic defocus, which was discussed probably in great detail, which trigger ocular growth. And there are many neuromodulators involved there, which finally leads to extracellular matrix remodeling and an excessive axial elongation leading to the progression of myopia. So digital health means it is a collage. It's an umbrella term that encompasses digital therapeutics, self-monitoring devices via technology. So what are these digital interventions? We have certain software interventions like apps and games that children can play. These are highly controversial because on the one side we are saying don't use the screen, and on the other side we are saying there are screen apps which you can actually use. And second is we have self-monitoring devices and apps which aid in continuous remote monitoring. So these two things are digital health interventions. This is a device for that. AR technology means, see, there is something called wearable devices which can be worn, and they simulate outdoor environments and vision tasks, and reduce the eye strain, ensure improved posture, and they again, we can incorporate this peripheral defocus into those devices also. So all these devices are such examples, and I will just be focusing on one such. That is the NED, or the AR smart glass. This is worn just 2 centimeters in front of the eye. The basic thing is the image is projected right into the retina by this glass itself. So the eye does not need to do anything. The eye is in passive mode. So when such glasses are equipped with a light transmissible part and an opaque part, then they become an AR computer, and they can be, actually connected to your smartphone also. And what this does is this light transmissible part is equipped with convex lenses. That peripheral defocus thing can be combined with this also. So this is where it is going. So these many advantages they are saying for these NAD glasses. There is no glare, there is no need to turn on lights because you are using sunlight, no reading glass, etc., etc., etc. But the thing is that the FDA is not yet cleared this. That means there are regulatory problems with this glass. So these are some other devices. The first one is a Kubota glass. It's a wearable device designed to control myopia control. It projects defocused images to the peripheral retina. Again, peripheral defocus. Now, there are some vision training exercise glasses available. And the second one, this one is a clue clip device. It's a wearable that can detect light intensity exposure levels and it can modify unhealthy work patterns. So digital health has, much patient satisfaction and engagement, and it is tailored to individual patient needs. But there are challenges like high cost, lack of robust clinical evidence, etc. Now we come to the next section of genetics. This addresses the root of the problem. So these are the key genes. The ones that I have highlighted are some of the key genes. And gene therapy, that is virus-mediated gene delivery, etc., are being explored to correct genetic mutations, reversing myopia progression. Whole gene replacement is also on the queue. These are all, research and experimental right now. But this is not like that. It is light and environment-based therapies. Outdoor exposure is probably the most affordable form of light therapy. It works by triggering retinal dopamine release and reducing accommodative strain. At least 2 hours per day is the recommendation. And there are many challenges in its implementation, including UV exposure risks. Architectural interventions means modulate classroom lighting itself to meet these luminance requirements. Now, apart from this, there are certain emerging light therapies like using red light and even violet light. So these are the specifics of these light therapies, which I will not go into. But I'll only say that RLRL is leading this game now. And long-term safety data is again limited for that, even for RLRL. And there's a rebound effect also. After stopping therapy, there is supposed to be a rebound effect also. These are concerns regarding RLRL. Whereas violet light therapy, the evidence is very limited. It's RLRL that's being explored. So the challenges are, again, this is FDA unapproved, cost factors are there, accessibility factors are there, long-term safety factors, and we don't know the optimal dosing protocols as such. Now coming to the AI in myopia. AI apps rely on big data. It can be machine learning, deep learning, etc. And in children, it is used for mass myopia screening and predicting progression, and also for ortho-K results and to evaluate, how to fit it correctly, etc. In adults, it is for predicting myopia-related complications and surgical outcomes. AI again has the promise and the peril. The promise is that it is enhancing diagnostic precision, reducing strains on resources, and huge economic advantages. The peril is about the data quality and regulatory issues. So again, the last one is pharmacotherapy. It acts on this neuromodulator pathway. And these are all the target molecules of pharmacotherapy. The current status is that human trials are there only for atropine, pyranzipine, and methylxanthine. Only these, of which atropine is, of course, the most consistently used now. And pyranzipine is still to, have acceptance. And in clinical trials, these are the molecules being tried, that is ketorolac, riboflavin, brimonidine, etc. But it's largely experimental, and no pharmaceutical agent has been actually approved by US FDA right now. So in short, challenges of emerging technology are cost, availability, accessibility, regulatory approval, and robust scientific evidence. Combination therapy may be the way to go. And the most common combination advised is pharmacological and optical. That means, for example, ortho-K and atropine. We have also others coming up, other combination therapies. So in summary, emerging interventions show promising results, but there is no single solution for all patients. Individualized and combination therapies offer the best chance, and the challenges are adherence, access, long-term data, and population-wide implementation. Future success will depend on early intervention and public health engagement. Thank you all for your kind attention.